This conference will now be recorded.
Hello, everybody. It's John Antonucci. It's March 25th, and this is AnCan's high-risk metastatic advanced prostate cancer discussion group. We're going to get going in a minute, but first I want to take a moment to thank some of our sponsors, Bayer, J&J, Myriad Genetics, Telix, Blue Earth, Foundation Medicine, and Novartis. No requirements are made of us by their sponsorship. We're going to all talk about our own personal experiences in here, so we don't want to take it as medical advice. So go back to your doctors with any ideas that you pick up and discuss. We have one person who's pretty much new, been here before, and I have one guy who is going to have to leave early. So I'm going to do things a little bit out of order first and go to Wes first. So he's going to be free to leave for his appointment. And then I'll get to the new guy. Okay, Wes? Where are you?
Oh, I see him. But
Your screen is blank too.
His screen is blank. Oh, now it's not blank. And are you there, Wes? Because if not, you'll have to wait until we're done with it. Are you there?
Can
Yes.
you hear me now?
Yes.
All right. Quick question. Brother-in-law had a biopsy today. He has a level 4 MRI. I'm guessing he will join one of our groups. My question is, he lives in Connecticut. I think he ought to go to Yale. He ought to go to Sloan Kettering. I don't remember the recommendations for that part of the world, but I wanted to pass that on to him so he could get located at an excellent place ASAP.
So we do not take questions for people who aren't present, Wes, because otherwise we'd be spending so much time with people bringing information. He's very welcome to a talk. We can help you decide which group. Please ask him to join the group, and then we'd be happy to help him.
And you can also write to me, Wes.
Understood. Thank you so much.
I live in Connecticut also. It's
Yeah,
DR.
I'll put it in the chat. I'll put it in the chat window, Dr. John.
Okay, great.
Yeah. Thank you.
Okay. What town is he in, by the way?
New Canaan.
Okay.
But his mom lives in Manhattan, so he's back and forth. Plus options, and you guys talked about this several times, and I only remembered a bit. Oh,
all right.
But he's got
one of us.
I know him. So.
Okay, write to me or Rick, and we will be glad to enlighten you. So, Dr. Paul, how old are you?
85.
That makes you the second oldest guy in the room, I think. Not the oldest. And where do you live?
Virginia Beach, Virginia.
Okay. And you're a vet. I know that. I'll put that in here. We do have a veterans group if you would like to learn about it.
Yeah, I attended last week, and Jim Marshall was very helpful.
Oh, great. Okay, he always is. Give us a little background now. I know you can present yourself in a very concise way, but what we usually start off by telling us when you got diagnosed, why you got diagnosed, and some of the earlier parameters of your illness, and then the course of your illness.
Well, 2000 PSA was 6. It had been 3 or 4 before that, which we know is not normal for a 55-year-old, but at that time it was, quotes, normal. Biopsy done, radical prostatectomy, rather early PSA recurrence, salvage radiation, again PSA recurrence, androgen deprivation therapy, clinical trial at Johns Hopkins, became non-metastatic castrate resistant in 2008, started at the time, no other therapies available for non-metastatic, started estradiol, transdermal estradiol, which I've been on since, became metastatic in 2013, had radiation therapy to the vertebrae and Provenge, suppository T, then had enzalutamide, abiraterone, darolutamide, BAT, bipolar androgen deprivation therapy, and I've been just kind of coasting along. My PSA doubling time is about a year, but it's now PSA is 160, and my recent PSMA PET showed some liver metastases and bone metastases, and that's what got me on the VA to try to do something other than docetaxel, and Pluvicto was available and had the first infusion 2 weeks ago with very well tolerated, to my surprise, compared to my experience with others receiving docetaxel.
So you've avoided chemo altogether through all this?
Yes.
So so now you're on Pluvicto, estradiol, and darolutamide, right?
No darolutamide. That
Oh,
was
that's gone too.
discontinued. Yeah. Just the estradiol patches,
Yeah.
and with a castrate T, and the Pluvicto is the only active therapy other than the usual other stuff, vitamin D and exercise and da.
Okay. And who's your treatment team now? It's probably a combination of VA and private, or what?
Well, the VA has seen me once a year for the routine checkups, and they agreed to have Pluvicto under the local medical oncologist community, and my urology is followed by my prior practices, younger individuals. So I'm followed here in Virginia Beach by, fortunately, people I've known for a long time.
Who are they?
Virginia Oncology Associates, Victor Archie, and Mark Fleming, and Urology of Virginia, Mike Williams.
Okay. The reason he can do that so fast is because they beat it into our heads right from the first year in medical school to give a very concise and rapid presentation of a case and yell at us if we don't do it right. So right now, you decided to come back. Why?
I'm sorry, Rick, what was the question?
Why did you decide to come back to AnCan?
Oh, two reasons. One, I really have not met anyone who was aware that veterans can receive Pluvicto by the VA care pathway prior to docetaxel. In the community, that's not the case. Medicare won't cover it.
No.
And I was put onto this by a medical oncologist at the University of Washington in Seattle, who himself, although working at the VA, said, I've just come across this in the past 2 or 3 months and try to see and it was so, I'll say, patient friendly, seamless, and the medical colleges here had no idea that this was available to Agent Orange veterans. So I wanted to be sure as many of your folks knew about it. And I guess they do because you mentioned it. And to listen in to what you all are talking about. So I'm coming back to listen and to share.
Thank you so much for doing so. Have you had any genetic tests, Paul?
Yes, and not somatic, just the germline negative. My somatic tissue was biopsied at MD Anderson for a number of markers, but not at the time for any somatic mutations.
And that was way back in 2000.
Yes.
Okay, yeah. So you might or might not have some new, you might or might not have some new genomic findings by now.
Yeah, and I asked about a liver biopsy, and the idea was, well, it's not going to, there is some risk with it. It's not going to change what we're going to do right now, which is the Pluvicto, regardless of what the results of somatic mutation might be. So let's proceed with this, spare you the biopsy and possibly the morbidity, and that may be something in the future.
Okay. Yeah, if it's not going to change treatment, why make your liver bleed, right?
Yeah, and the uptake, the interesting thing, and maybe you all know about this, but I've read quite a bit about the response rate of Pluvicto based on SUV, which is the uptake of the PSMA PET scan, and there's a term whole body SUV uptake, and I've tried to figure, that was not mentioned on my PET CT scan, as to each individual lesion was given a SUV score, but a whole body SUV, which I've since read under Sauter and Michael Morris, is a pretty important prognostic indicator, but have not gone back to the original readers, and I don't know if they have the equipment here to do that, or if it's just a simple calculation as to adding up the SUV scores and dividing by the lesions. So do you all have information on that?
No, we haven't really run across it. I guess it's a way to attempt to estimate tumor burden,
Right.
which you can also do in other ways, blood tests and things like that. But I don't know how it's calculated. It's probably, as you say, I don't know if it's weighted. Like if you have a big metastasis in one spot and a small in another one, does the bigger one get weighted more heavily in any way? I don't know. Anybody here ever had a whole body SUV calculation done on their PSMA PET scan? Not yet.
Yeah.
I haven't
John,
really
I've
seen it
asked.
much in the literature either. Carlos?
I've asked for that, and they just, it's like not forthcoming. In fact, talking about SUVs, the last time I actually had readings with each lesion was in January of 24. And subsequent PET scans, they just say it looks brighter, or it looks less uptake, and that's as far as they're going now. So I'm not sure what's the story with SUV anymore. Maybe it's just my area of the woods.
Mm-hmm. I'd like to just throw it open now. Anybody have anything that they would like to ask Paul or contribute their own experience? Some of us have been in his spot. Len, please. Then I'll get to you, Larry.
Larry, please use the hand up function. If everybody...
Yeah, I'm trying to find it.
Okay.
There it is.
You got it? Yes. If you can use the hand up function, it makes it a lot easier for the lead moderator. Thanks, guys.
So, Paul, very curious to know, what are your feelings about chemotherapy that you've gone now about 25 years of therapy and never had chemo?
Yes, well, that's a good question. My disease, 25 years is a long run, and it's always responded somewhat to the interventions that were applied, and then of course it recurred, all based on PSA and then subsequent PSMA PET scans. And I experienced with patients over the years who I was caring for, the response or the side effect profile of docetaxel, especially in folks in their 70s. And it was unpleasant. And the weight of the benefit of didn't seem to me, the older I got, to be worth the life extension it might provide based on the suffering and discomfort that it did provide in the therapy regime. So yeah, if I had in mind that perhaps I would take one dose and scream and shout and complain and say, no mas, and then maybe be eligible for Pluvicto. But I certainly am trying to avoid it and will avoid it.
And you are, I think, on estradiol therapy longer than any of our members that I'm aware of. How has that worked for you? Have you had any side effects other than possibly gynecomastia?
Yeah, no, the side effects have been all positive. My bone health, obviously, I've had some spinal surgery based not on malignancy, but on discs. And of course, I've had periodic bone mineral densities, which are great. And I say I've had the necessity to stop estradiol for a clinical trial at MD Anderson in 2012, and went back on LHRH analog, and boy, I felt worse. And then when the trial was over and I could switch back to estradiol, I felt better. So I am convinced that it is a better quality of life. I have required, I had radiation therapy, which to the breast, which stopped the gynecomastia, but I had very sensitive nipple areas. So I proceeded with a procedure that transected the T4 intercostal, which innervates that area. And that solved the dynia problem of estrogen.
And just one final quick question. Were you under the care of Dr. William O at some point?
No, I know him well, and I've consulted with him at conferences, but not under the direct care, no. My estrogen was started by Dr. Charles Myers, who I'm sure some of you have know, and that was a very wise decision on his part.
Yeah.
Thank you.
I know it's an awful long time ago, but what was the result of your very first biopsy way back in 2000?
Yeah. So that's an interesting story. It was read by a very good pathologist out in the University of Washington, 4+3, negative margins, negative seminal vesicles, so T2. And then when I went on clinical trial, of course, they wanted to review the biopsies. And one went to Stanford, and it went from 4+3 to tertiary 5. And then it went to
same slides or a new biopsy?
Well, that's the issue. Don't know and never was able to get both pathologists to look at the same slide. Well, I went to Johns Hopkins, where I became a margin positive 3+4. So I grade went down, but the pathologic stage went up. Here again, they were all quotes GU pathologists. The last one was Epstein from Johns Hopkins, but I talked to him, but I could not get be assured that they were looking at the same piece of tissue.
Mm-hmm. So what do you think it really is?
I have to believe it was more a 3+4 25 years later. I don't think I was had much 5 or any 5 to speak of.
So you've been on 2 trials, one at Johns Hopkins and one at MSK?
MD Anderson.
Oh, yeah, I'm sorry, MD Anderson, yeah. Okay.
And the last one was the trial combining abiraterone and enzalutamide. And you would think that would have been a powerhouse. You were hitting it from the production side with abiraterone and the androgen binding site with enzalutamide, but my PSA just kept going up on both of them over 6 months. It was a big disappointment for me and for the clinical trialists. And that trial actually did not pan out, as you all know. It just, although it looked like a great combo, it didn't pan out.
That's the one where you had to stop the estradiol, probably.
Correct. Yes, yes.
Larry.
Yes, 2 questions. Well, I have one answer and a question. I had a PSMA PET scan at Fred Hutchinson Cancer Center in Seattle, and I don't recall them giving a total body of uptake, but they did list all the uptake areas, whether they were cancer or not. They gave me an uptake rate for various organs.
Yes.
Yes. And so that's the answer that I wanted to give you. But my ears perked up when you said you were on estradiol. I've been using estradiol since April of 2024, and it's suppressing my PSA and testosterone very effectively. And I would love to learn your history with that.
Well, since I've been on it since 2008, other than having areas of bone metastases radiated and also having Provenge, and by the way, after 5 years, about 8 years after that, I was doing well enough that I asked them to test all my immunologic parameters to see if perhaps I was an unusual case of maintaining an immunological profile that was favorable. And really, there was no evidence of anything that would have made them to think that. So with regard to the estrogen, I just maintained it because the quality of life, it suppressed T, which is what we are after, and the quality of life, just general well-being, was no comparison with my experiences with LHRH analog, which was Lupron at the time.
Right.
And your bones are good after 17 or whatever years.
Yes, yes.
That's wonderful.
If you're willing to exchange email addresses, I'd like to get more detail and share some of my research with you, if you like.
Yeah, yes.
Okay, I can't find my chat, but
you got those little square boxes up at the top right, Larry?
Yeah. Oh, there. Yes.
It's going to be tough. It's going to be tough because Dr. Schellhammer is also on his phone, and it makes it very difficult for him to get to the chat. So maybe the best thing is I'll make a note, and I will make sure to send an email so that you guys can share addresses, if that's okay.
Look forward to it. Yes.
Okay. Rick, I'll send you directly.
I have your email address.
Oh, thank you very much. I appreciate it.
Yeah.
Oh, sorry. Go ahead.
Well, and at the AUA this year, there'll be a poster with regard to estrogen, because as most of you probably know, it was a patch trial was presented at the European meeting and demonstrated equivalence with regard to testosterone suppression and clinical outcome, but quality of life benefit was, and bone mineral density benefit, and the cost differential. If you don't have to take Extiva and you don't have to be monitored by that, and you don't take the heavy duty cost of the LH oral analogs, estrogen, I think, will make a comeback in general.
By the way, Dr. Wassersug is interested if anybody is going to AUA to maybe connect with them. Anybody here going to AUA? Okay. Al, hi. I didn't see you come in, but you got your hand up.
Yeah, I came in late. There's something I just couldn't log in for some reason. I just wanted to say to Paul, I'm also a Dr. Myers patient, and I've been on estrogen since 2012, so not as long as you, but I second everything you say about it in terms of feeling better, better bone health, etc.
Yeah.
Just wanted to throw that in there.
Where you do beat Dr. Schellhammer, Al, is that you were diagnosed in 97, right? Is that right?
1995. It'll be 30 years.
95. Okay.
Longest.
And estrogen worked for 20 years.
Yeah.
Gary Peters and then Carlos.
And can I just say before we move on, Dr. Schellhammer, Al Latimer has been on Pluvicto, is it twice or three times? I've lost count.
I did it. The first time I did it was before I had chemo. I had 6 doses, and then I did it again after chemo, 4 more doses. But the side effects got to be intolerable, so I stopped.
And what were the side effects that were intolerable?
Well, the worst one for me was severe dry mouth, severe loss of sense of taste.
Yeah.
Fatigue was not good either, but it was the dry mouth that really just, I was afraid it was going to get so bad that it wouldn't come back.
Mm-hmm.
So I stopped.
Thank you.
Because I've heard of people that have gotten so bad that it becomes permanent.
Yeah, we have a couple of other people tonight also who have done Pluvicto, Dr. Poole. So we've been working with Pluvicto in this group since 2015 or 2016 when we had an Australian gent who was on the trial in Australia.
Mm-hmm.
Gary?
Doctor, you were taking estrogen to the exclusion of one of the LHRH drugs, or plus?
Correct. No, to the exclusion.
Instead of.
So what kind of quantities were you taking? Dosage?
Yes, it's a 0.1 milligram estradiol patch that originally I used 2-3 times a week, 2 every other day, and then I cut back. Now I use 2 on Monday and Thursday, but I think that can be, and I believe basically my testosterone, my testicles are burned out. And if I didn't have any estrogen, I would still maintain a castrate T. But I would also be less comfortable. I use it now to maintain my bone health, my metabolic profile, make sure I don't have any hot flashes, just to maintain feeling reasonably well.
Do you know what well, I'm sure you know what your estradiol level is?
I used to, but I haven't measured that in many years. So I can't say I do now.
And also, what did you say the name of the procedure was that you had done on your breast?
Well, it was a modified mastectomy, but the major issue was to transect the innervation to the nipple, which is the T4 intercostal nerve. And I learned more about it reading the literature about breast cancer and the problem women have with their procedures, radiation, partial mastectomy, and often the pain that occurs as a result. And my surgeon and I said, that's what we got to do. And it worked very well.
Thank you.
Thanks, Gary. Carlos?
Hi, Doctor. I was going to ask the same question about what kind of dosing you were taking. We've heard other regimens, but that sounds like a reasonable way to go. But the bigger question is there a value to monitoring your estrogen level? There's a particular test you can have, and what are your thoughts?
Yes, and maybe some of you know Richard Wassersug, who's at British Vancouver, who has really been, for the past almost 25 years, a proponent of estrogen. And there is a whole group now of men, and I've been introduced to them over the past month because of this patch trial and AUA poster, and the number of permutations of levels and of applications. So men are using gel now. They're applying it to scrotal skin, which has an extremely greater uptake because it's thin and there's not subcutaneous fat. So you can probably get by with a lot less application to get the level of estrogen that you would want. If I were in my 60s and 70s, I probably would be monitoring estrogen. But as I say, I've kind of gotten in a groove, and I'm just happy with what it is.
So do you feel that it's protecting you regardless of your T level? In some way? Metabolically, bone, and things like that?
Yeah. I mean, my T level's been castrate forever. And
if you stop the hormones, it would probably stay down there, but still you feel that you're getting a protective effect, either metabolically or musculoskeletally.
Yes.
Okay.
Yes.
If you go to our website afterwards, anybody here, and you put in the search box Wassersug, you'll find a couple of sessions that Dr. Wassersug has done with us. In particular, we did one about a year or 2 years ago with a bunch of guys that were using E2 and talked to them. Dr. Wassersug was in the group 3 weeks ago to talk about the patch study. He's on our advisory board, so we've got quite a history from it, quite a history with him. I'm worried because I know John has got an awful lot of people that want time tonight. So let's go to Jack and then maybe move on, because everybody else has had at least one shot at talking to Dr. Schellhammer.
Have you finished, Carlos?
I just wanted to. I was going to ask about the use of tamoxifen, if that has crossed his thought indecision process, but we can talk about this offline. I'll just send you a PM here.
Let's just ask now while you've got the floor. Any comments about tamoxifen, Paul?
No, I have not had any experience with it. No.
In my reading, I came across that, and it was because I had tried the radiation. I was still having nipple enlargement and a lot of tenderness. And then I read that you could actually reverse that because it would block the estrogen to those glands that swell up with estrogen. So I stopped the patch and went on a double dose. And after about 2 weeks, went on to a base dose and started my patch back up. that took care of that problem, and the gynecomastia is not an issue.
Good.
However, it's a pill, and just like estrogen as a pill can cause cardiovascular problems, so can tamoxifen. And that then brings the next question: can we get tamoxifen in a patch? And unfortunately, in the U.S., it's not an option yet. I don't know about other countries. That's just my comments. Thank you.
Rick is right. I have something like 14 or 15 people to get to, so I am going to push on. Larry has made a comment in there, and it's an important one. It has to do with injectable estrogens, which have a different side effect profile than cutaneous estrogens or oral estrogens. And it would be maybe later on, if we have some time, we can go back to that. And Jack, I only want to get your comment if it's a quick one. Can you make it quick, Jack?
Me personally, or in relation to Dr.
In a relationship to Dr. Paul.
That can wait. It's just there was a curiosity that can wait for another time.
Okay, we'll try to get to it at the end if we can.
Yeah, and one very quick question. Who was the med-onc who referred you to the VA at UW?
Bruce Montgomery.
Thank you. Thank you.
Well, welcome back. I'm sure you already know our schedule. Come anytime. And I'm sure you'll see Jim again, too, in the vets group. First guy on my list is Steve Rue.
Can I just tell Dr. Schellhammer, because John would never mention this, but Dr. Schellhammer, Dr. John spent most of his clinical time either at the University of Connecticut or at the VA in Hartford for most of his career, and very often shows up to help moderate that VA group.
Where are you, Steve? Yeah, I'm looking through my pictures here, and I'm not finding him. Well, we'll keep a lookout for him, see if he comes back. John Maxwell.
I'm here. Okay, very good. So I'll be brief. I started orgovyx about 6 weeks ago. A couple of weeks ago, my PSA had fallen from 25 down to 4.9. And my testosterone fell from something high, I don't know, it was in the 450s, down to 13. On the 22nd, I'm getting high dose brachytherapy boost at Loyola, and then I'm going to get beam radiation after that, no surgery. Couple of questions. Number one, how quickly will the orgovyx bring down my PSA, hopefully, to below 0.2? What's the expectation? How long will that take?
So you've gone from, I'm looking up your original, 12.5 to
12.5 on finasteride, so doublet, 25.
25, so-called, to 4.9 in how many weeks?
It's been about 7 weeks, 6-7 weeks.
Of course, we don't have nearly as much experience with orgovyx as we do with the others, but I would think by 8 to 12 weeks you should be down to castrate levels. I mean not castrate levels. We're talking PSA, not testosterone. You're already at castrate levels on your testosterone, and the testosterone probably going to go down even a little bit lower. But, does anybody have any orgovyx experience? How long did it take you for your PSA to go completely in the tank? Larry?
Yeah, I started orgovyx in May of 2024, and and my PSA was already suppressed a little bit with some estradiol, but I ran out of supply, so I started on the orgovyx, and by October it was 0.048.
June, July, September, October. That's 16 weeks about. Anybody else have a time frame? Gary.
Just talked to Dr. Sokolova about that today, and she said 3 months, 3 to 4 months.
3, 4, so it's 12 to 16 weeks.
And the measurement was taken at about 3 to 4 weeks. Was when the measure was taken?
Oh, yeah, you got time to go.
Okay.
So according to our AnCan survey that we just did, it's 12 to 16 weeks with an N of 3 or something, so it's not valid. 12 to 16 weeks. So I bet you by your next one, your PSA will be quite well suppressed.
Okay. I'm just starting on the journey here. I'm a newbie, right? I'll be very brief. I'm meeting with Dr. Smolowitz at U Chicago on Friday.
Good.
I was going to meet him 2 weeks ago, but I had emergency gallbladder surgery.
What timing?
And I was going to try to do a virtual meeting from my hospital bed, but they said that was not allowed. So I'm finally meeting with Smolowitz on Friday morning. So,
okay.
And I'm having hot flashes, but other than that, I feel generally good. So
we've had people attend meetings from us, our group meetings, not virtual meetings with doctors, but we've had people attend group meetings from hospital beds.
Yes, we have.
I don't know we have time to get into it in detail today, but we've got a lot of solutions for hot flashes. Come back and talk to us about it next week or the week after, and if they get intolerable, we've got a lot of good advice on hot flashes.
Thank you. I just want
to today, if I get through everybody today, bring it up.
I think you need to losing weight,
December,
Mr. Maxwell. You're looking too skinny now.
Since early December, I've lost 30 pounds as of this morning.
Wow.
30.
Very good.
And I went on pretty much a straight vegetarian diet, so it's great. So this call means the world to me. Thank you, thank you, thank you. It's just good to be here among fellow heroes.
And you still with Dr. Eggener then?
No.
No,
I did not do surgery. I'm doing radiation. So
he's gone. And who was your radiation therapist?
My radiation therapist, of course, you asked me, and now I got to pull up his name again.
It's Dr. Harkenrider.
Harkenrider's doing the brachytherapy, and I don't know if anybody's doing brachytherapy. Dr. Andrew Lee is my radiation oncologist, and he studied under Stanley at the U Chicago.
Stanley Lou.
Stanley Lou. He studied under Stanley Lou. He's outstanding. I like my team.
Excellent.
And Dr. Eggener was very gracious when John made the decision to do radiation therapy.
He was very gracious. He sent me just this beautiful email. Very, very nice. Impressed. So I'm good, guys. Thank you.
All right. Has Steve come back? Don't see him. Jack.
Yes, sir. Well, I certainly was interested in Paul Schellhammer's presentation because I'm the other 85-year-old here who's had not 25 years since I've been diagnosed, but 22. And then when Latimer, of course, is 20, so he is the longest. But I'm celebrating a bit because I started my vacation on Friday, my holiday away from doublet therapy. And I'm excited. I don't want to get too excited. I'm afraid I'll be let down and disappointed if it comes back and bites me on the ass too soon. However, I'm hoping that I get some time because within a few days, I'm starting to feel a bit like my old self, not in terms of muscle strength, just in terms of crispness in my thinking, not as much brain fog. I'm starting to, feel, less fatigue and more enthusiasm. So it's exciting to be offered this. I feel like I've been poisoned, and I've never. Basically, I feel like the poison is out of my system. It's coming out of my system, and I'm feeling so much better. And I'm hoping it lasts for as long as possible. So I wanted to share that with you because that's where I'm at. I mean, a lot of side effects that I had previously, like feeling I was going to fall on my face constantly. Today, I'm able to walk without having the feeling that I'm going to stumble and fall as easily. So I don't know how much is placebo and how much is realistic strength in my legs. I don't know. But whatever it is, I'm excited, and I just wanted to share with you guys. So 23 months on darolutamide, 21 months on orgovyx, and I didn't go the full 24 months because both my radiation oncologist and my medical oncologist said, a couple of months more isn't going to make that much of a difference. Go for it. And, at 85, going to be 86 in August, why not go for it? How much time do I have left anyway? I'm hoping for as much as possible, but gee, why not have some quality of life? And that's where I am.
I'm very pleased to hear that.
Thank you.
Rick, you got your hand up.
Dr. Jack, you're the expert to answer this question.
Okay.
In general, but to what extent, how long have you been off the orgovyx?
Since Friday.
Since Friday. To what extent do you mentioned the placebo effect, Dr. Jack? To what extent do you think this is a placebo effect? Oh, by the way, whatever the reason is, we're delighted for you. We really are.
I'm not.
Or should I ask your colleague, Dr. John, whether he thinks it's a placebo effect?
Frankly speaking, I don't give a flying fuck. I feel better, okay? All right? And whatever it is, it is. All right? And if it's a placebo, God bless me for being so, susceptible to the placebo. And if it's not the placebo, isn't that wonderful? But, frankly, I really don't care. And I'm not going to quantify and give you a percentage because who knows? Whatever it is, it is.
Okay.
Larry, you got something for Jack?
Yes, I do. It's a kind of a testimonial. I wanted to ask, are you on a regular exercise program? And I joined the YMCA's Livestrong program, and I found out I couldn't balance on my left foot hardly at all when I started. 5-6 months later, I can now balance pretty good. So the exercise has helped. So what are you doing for exercise?
Well, I live in a community where I have a huge gym. I go to the gym every day.
Oh,
I work out. I've been working out my whole life. I go to Tai Chi 3 times a week. I use the treadmill. I use the elliptical. I do free weights and machines, and I do everything I can possibly do. But I'm not I'm not strong. I'm not strong as I was 2 years ago, and I'm hoping that occurs as I get my testosterone back.
Yep. Thank you.
I practice balancing on both legs.
Well, it surprised me, and I
Thank you,
didn't
David.
exercise for a couple of decades.
Thanks, David. It's good seeing you. Say what?
Carlos.
I quit exercising for a couple of decades. That was a bad idea.
Carlos, can you catch us up?
I just switched over to off a headset. Can you hear me okay?
Yes.
We sure can, Dr. Carlos.
All right. Thanks for having me back. It's been a better part of 2 years.
Where are you now, by the way? Are you
a lot
in
of things
Tucson?
done. I'm in Tucson.
Okay.
Yeah. So I did want to just give you the highlights of my treatment, which was I ended up finally getting through Pluvicto. That started October 23 and ended in June, end of June of 24. Took longer than usual because after my third dose, my bone marrow took a real big hit, and my white cell count dropped to 1.7, the ANC of 0.64. So for those of you who don't know what that means, it means that basically I really couldn't fight off anything, and I had to basically sequester myself. It is a reversible thing with some of the medications they can give you, and within about a week's time, my numbers were shooting back up again. Nevertheless, you get a fever and you're on this stuff and you're set up for bad infection. So the good news that did set me back a couple of weeks, and then my Pluvicto people weren't giving everything every 6 weeks as had been planned, because they decided to start going every other week, and my schedule didn't quite fit in, so it got stretched out longer than it should have. For better or worse, I don't really know.
Same dose every other week, or did they fractionate it more?
No, it was the same dose for each of the 6 different treatments.
Okay.
Now, some of the questions that people may have along the way, the dry mouth business started right around week 2 or 3, and by 5 or 6, it's like it's there. I'm using eye drops. I'm using mouth lozenges. It's uncomfortable, and my big question to the tech was, what do people tell you? How long does this last? And I could not get an answer from people. This has been 8 or 9 months now since my last treatment, and I can tell you that my taste is mostly back. Beyond that, the dry mouth is problematic at times, but I'm down to just a lozenge or 2 once every second or third day. Sometimes I'll wake up at night and I'm just like, my mouth feels like it's going to, tongue's going to stick to the roof of my mouth. I'm going to choke to death. But I think we've all experienced that over our lives for some reason or other. The Pluvicto effects, I think, had what I'd heard previously. My initial PSMA was 4.34 pre-treatment. 2 weeks after, it expectedly rose to 6.4. And at 4 weeks, you saw just a slight bump down to 6.1. After over the next 2 treatments, it stayed right about 6.2, and didn't really see anything until labs for my 4th treatment, at which point my PSA dropped to 2.07. Since that time and finishing my last dose of Pluvicto, went down from 2.07 to 1.2 to 0.6. So I've had a really good result. When I saw Dr. Sarter, he said, you've had an exceptionally good response. At this point, if you're down to just a couple of spots, you might consider getting radiation. And so that's going to be one of my questions about doing scans with low PSAs. To get you fully up to date, I am now 38 weeks due for labs next week. At 34 weeks, my numbers they just kept dropping. 0.33, 0.25. This is every 6-week labs. 0.18, 0.09, 0.05. So it's lower than I've ever seen it, and I'm really grateful.
Good.
As far as monitoring this with scans, I did get a scan after my 4th treatment. It at that point was showing decreased uptake in several different not lymph nodes. Actually, I did have some mediastinal lymph nodes, but I mostly have bone lesions, and they were the report lists them as diminishing. So let's see here. I should say showing moderate activity, previously intense. And so that was pretty much across almost all of them. When I finished my Pluvicto at about 6 weeks out, I said, hey, can we get another PET scan to see where we are? And of course, by that time, my PSA was less than 1. And the response I got was not what I wanted to hear, which is, well, we know you've got a response. Why do we need to do anything more? And that's when I consulted with Dr. Sarter, and he said, well, it would be good to know that if you have a few lingering lesions, and especially if they're in areas that are potentially problematic, that would be a consideration for you to go back to Rossi and get protons to those areas. In other words, if they're staying hot, maybe you should go after them. I have not gotten a PSMA scan. I'm due to see my doctors in about 2 weeks. I did come up with an article that I don't know if you have heard about it or have any suggestions where else to look, but this is a clinical news molecular imaging. I don't have the actual, oh, here we go. There's an actual a citation for it. But they talk about a study in Chicago where, despite having 0 PSMA, about 25% of those people still had lesions to be found. So I know that the cutoff for getting PSMAs had been dropping and was probably less than 1. Last I looked at what the numbers were showing, but now that you're less than 0.1, how hard would you suggest I push for it? Or do I just go back to my Mayo people who will probably want to see where we are with it? So I'll leave that summary to you, and if you have questions, please, I'll try to answer them.
So Carlos's question is, how hard to push for a PSMA as a biomarker of Pluvicto response when his PSA is 0.1?
It's less than 0.05. It's half of 0.1.
It's 0.05.
0.05. Okay. Yeah.
Wow.
It's like, I wanted it about 3 months ago when it was still 1, but they were saying no. And at that point, my oncologist had turned me over to the nurse practitioner who said, well, I got to run it by the boss and see what they say. And then no answers, which then begs my second question. I need suggestions for oncologists who have treated people who have been the length of this run and found a response, but where do we go from here? I mean, how do we monitor this? Or we just wait until the numbers go up and then say okay, let's wait till they're high enough so that we see something. This is what happened to me the first time, and by the time we waited for it to get to over 0.3, I had 15 Mets, and it's like, I'm a low PSA producer. We've talked about that. You know that. Where are we?
Well, who's your quarterback doc right at this point, Dr. Carlos?
I'm currently seeing Dr. Rosenberg with Arizona Oncology in Tucson.
Yeah, well, I mean, we've talked about this a lot, but you need a GU med-onc as your quarterback, because a good GU med-onc is not going to allow you. He's not going to have a nurse practitioner who questions. He's not going to go back to his team. He's going to say, yeah, we need to do it. So if your quarterback doc was Dr. Sartor, although obviously that's not very practical for you, I think you'd have a different result. I probably would say to you, as long as you're spending enough time in Tucson, go make your quarterback doc Alan Bryce at City of Hope, because he's a really great doc.
I have him in my back pocket, and I haven't made that appointment.
Well, I've actually been in communication with him the last couple of days, totally unrelated. He's very responsive. He's got a great reputation. He's a great researcher, and he really understands. And I think as long as you stick with Arizona oncology, you're going to find yourself in the same situation as before. So we don't have any good alternatives in Tucson. But if you were to ask who my preferred doc would be in Phoenix, I would definitely say Dr. Bryce is well up there. He's probably in the top 10 in the country, and he's moved from Mayo to City of Hope. He's chief oncologist at City of Hope, and we really like him. I like him. He's always been very responsive to us at AnCan.
Yep.
And very kind and compassionate and good doc.
That's been my experience with him as well for the 2 years that he was at Mayo, and we would go and see him there. But at this point, when we found out where he finally moved to and went to go see him to reestablish that, at that point things were headed for Pluvicto, and it's like, all right, well, wait, because all my genetic studies have never shown anything that's targetable, and he's a big genetics guy, and it's like, okay, you do have the rest of the vision because you're around people. So I'm curious to hear.
I don't think it's all about genetics. It's about people understanding the disease and knowing how to treat it and how to monitor it. And I think that when you're not necessarily going there for what to do next. You're going there right now because you need somebody who really understands prostate cancer. And he does. And God forbid you need more treatment, then there's going to be all kinds of options, not the least of which is maybe to go back to Pluvicto and get more Pluvicto. But whatever the right thing is, my feeling is Dr. Bryce will do the right thing by you.
I would agree. And Dr. Sartor has the Alpha article that he's saying that if you don't respond, this is where I would put you next.
Where would he put you next? What was that?
Using the I'm trying to think of the name of it. It's the other Pluvicto. Is it actinium?
Oh, the other Pluvicto, the PSMA.
The actinium base. But you see, the alpha rather than the beta. But again, you see, you're dealing with Sartor. He has a bias in how he likes to treat, and I think that might be right, but it might not be right. And I think if you go to somebody who's a really smart and good GU med onc, they're going to be a little more balanced. So. I'm watching your time, John. I'm worried about you. You've got a lot of people.
I'm good. Thank you for the input.
Okay, Carlos, it's nice to see you again. Say hi to Sally.
Thank you.
Jerry, are you still here somewhere? Yeah, there you are, Jerry.
Yes,
hi.
I am.
Go ahead.
This is going to just be real quick. I have osteoporosis, and so I finally found a doc that's had 30 years experience in Tucson with osteoporosis. And I found out through him, because I've been taking reclass, a shot a year, and I've taken 6 of them. And he said you really shouldn't take reclass longer than 5 years. Better if you only take it for 3 to 5 years.
Right.
That's something I did not know, and I didn't know. I'm just telling you. The other thing, though, is Dr.
Hold on that thing. I think we did know. If I'm not mistaken, reclassed is zoledronic acid, isn't it?
Yes, it's a half dose.
Right. we've known for a long time that it's not good to stay on Zometa for a long time or reclass, depending on how you get it. So yeah, we were well aware, and it has an enormous half life. So what usually happens is people come off of it, and then they monitor, and a couple of years later you can go back on it. The other thing is that staying on it too long, it can really make your bones pretty brittle, because it makes them more dense, but it also, you lose flexibility, as I understand it. I've got to I defer to Len, because Len's very good on this stuff. But Len used denosumab mostly until he topped it off with the final dose of zoledronic acid. Go ahead, Len.
Yeah, you got it right, Rick. They do become brittle. And the way I got off of Xgeva was to get a one-time infusion of Zometa, which they have, through research, found that locks in the gains you made in the bone density. If you're already on Zometa, I don't know how that works. If you were to lock it in, I've never seen any articles on that.
It doesn't lock it in. I can tell you from experience, because when I came off Zometa, I'd gotten my bone density back up to about 2. I got it down to about 1, and the last time I was measured, it was 1.6 in my spine. So I was losing it again. So it didn't get locked in for my Zometa.
Right.
Okay.
But yeah, so as you know, they probably told you, Jerry, the longer you stay on these bone strengthening drugs, the higher the probability is that you'll develop osteonecrosis of the bone, which is disfiguring.
Well, I thank God I found this guy, because I'm going off it. I'll be off it in May. I had never heard of this. I guess it's a newer drug, but it's one that he uses. It's called Eventa.
Yeah.
EV.
That's another monoclonal antibody.
Yeah, but he wanted me to use it for a year and then go to Prolia. So that's all I wanted to say. Was I was not aware, nor did my oncs ever say, hey, you've got to get off reclass. So, but that's my fault for not looking into it.
It is a problem. I don't think they ever. I think the GU med oncs tend to prescribe these bone strengtheners and then forget about them, because we've seen that so often. And then people come into this group, and we say, well, how long have you been on it? Well, have you talked to your doc about coming off it? And then it gets to that conversation. So it's not unusual to find that nobody ever said anything to you. I don't know. Has any of you who are on any type of bone strengthener, has the doc ever said to you, time to come off? Oh, Dr. Hartstock said something to you, Jeff?
Yeah, 2 years. She said, take some medicine for 2 years and then you stop.
Yes, that's because she's a great doc. We love Dr. Hartstock.
I'm a big believer in specialists, and I think if a person has osteoporosis, and if they have, especially if they've had a fracture, I think it'd be better to go to an endocrinologist.
Yeah.
Well, John, I don't disagree with you. As a matter of fact, that's what Dr. E wanted me to do. But you try and find an endocrinologist that specializes in bone disease. There is not one in
That's hard.
Tucson. I was lucky that I found, he's a rheumatologist, but he's been dealing with osteoporosis for 30 years.
Yeah, rheumatologist. That's good.
Jerry, you offline, you should probably send his name to me. I should probably go up and get a consult with him. So I'd appreciate
Jeffrey
it.
Loomer, Loomer.
Okay, thank you.
Arizona
That's okay. I don't want to take the time in the group.
All right, okay. The next thing, real quick, and I don't know if it's only pertinent to me or not, but when I had my video conference with Dr. E, and she asked me what I was doing with cholesterol, and I told her I was taking a statin. It didn't matter. And she said, you've got to get off statins. There are other drugs for cholesterol, but since you're on Nubeqa, I guess it's contraindicated to be on a statin.
I don't know about that.
No, that's true only if you're taking rosuvastatin. Darolutamide will elevate fivefold the rosuvastatin in your plasma, but it doesn't affect, darolutamide doesn't affect any of the other
statins.
Yeah, so you can take any of the others.
We don't give medical advice, but you can take any of the others.
Yeah. Yeah.
Len's researched it, and you can tell Dr. E. Len said it's only rosuvastatin, and see what she says.
I'm not going to get in the middle of that.
Okay.
Although she
leave
recommended...
it to Joel. Joel will tell her.
Yeah, he can do it.
Yeah. Joel, we appointed you, General.
As a matter of fact, I'm on both of those drugs, and I didn't know about this conflict, so I will have to address that myself.
Which cholesterol drug are you on, Joel?
Restore.
That's rosuvastatin.
Correct.
Yeah, okay.
Len, that's not strictly true what you're saying. It's true that I've been into this quite deeply because I am a Nubeqa. The degree of interaction is 5 times more strong with, but the other statins are like a class B or class C drug interactions. So you have to be careful with the statins on Nubeqa. I take 10 milligrams of statin, and I added Repatha because of the cholesterol, and I'm under complete control. But you do have to take a look at the interactions, and you get rashes and other things. You can look at my doctor did, Dr. Audio researched the differences in interaction.
Larry, that's what Dr. E recommended to me is Repatha.
Yeah, well, Repatha, I take Repatha, and I'm taking a small statin also, and niacin, and that's my combination.
Like getting the shot?
What do you mean getting the shot? The Repatha?
Yeah.
Well, for me, I'm taking shots all the time. It's really a shot, and you have to. But I give it to myself. You put a little alcohol on it, hold it with one hand, inject with the other. It's not that big a deal. Every 2 weeks.
Yeah, every 2 weeks.
Yeah, I recommend. I was very successful with Repatha, and I still take a small statin. But if I increase the statin, I immediately start getting a bunch of reactions, and that's either of the 3 kinds of statins I've tried. But the one that Len is talking about is the one that has like whatever they call the maximum drug interaction danger. It's 5 times. So if you're on 50, 25 or 50, you would have to cut down to like 5 on the statin and add Repatha, and it was very effective for me anyway.
Well, I was on. Well, I still am. I was on 40 milligrams of pravastatin, and I dropped it to 20. But she was rather Correct?
Yeah, if you would go to Repatha, you could take 5 or maybe 0. That's my
Larry,
suggestion, not medical
Larry,
advice.
you took your hand down. Did you still want to make a comment about this?
Oh, the comment was for Carlos.
Oh, for Carlos. Oh, okay.
Yeah, the guy in my local support group has non-PSA expressing cancer, and I was wondering if that might be something he could inquire about.
Okay.
Anyway, I'm done.
Okay, Jerry.
I just wanted to mention that.
Okay, nice to hear from you. If you do run across any drug interactions, let us know. Because statins are very, very common, and we have a lot of men using darolutamide.
Gary has his hand up still.
Just a quick question about statins, atorvastatin. What does darolutamide do with atorvastatin?
It's on the list as potentially increasing the level of atorvastatin in your body, but it sounds like it's not nearly as big of a deal as rosuvastatin. So if you suddenly start getting side effects to your atorvastatin, you might have to do what Larry was suggesting and cut down on the dose.
Okay, right now I'm taking 10 milligrams every other day.
Well, you can't get much lower than that.
That probably shouldn't be a problem. I mean, I don't know anybody that had a problem going down to 5.
Thank you.
But 40, I had real reactions to. That led me down that whole research trail.
Cliff, do you want me to skip to you because you have to go, or just drop it for this week?
I really don't need to skip anybody. You got a lot of people, so why don't you just go ahead? If I can get back in later on, just pick me up on the end.
All right.
Okay.
Remind me if you come in, I might not notice.
Okay, I will.
Let's go to Joel.
Okay. First of all, I was able to stay in Houston at the Extended Stay America Hotel for free because I called the American Cancer Society, and they booked me the room for free. That's the procedure. You don't call the motel directly. You call American Cancer Society. They then call the motel with you on the line, and they make the reservation for you, and they pay for it. So I was able to stay in Houston for free as far as the hotel was concerned. And just so you know, as a reminder, the American Cancer Society also has 30 Hope Lodges around the country and one in Puerto Rico. And if your doctor happens to be in an area we're traveling to that has a Hope Lodge, then you can stay there for free. The only thing I would say there, probably need to make a reservation a month or two in advance because they're high demand. So for those of you who travel to your doctors, that might be helpful information. As far as Dr. E is concerned, I saw her last Tuesday, a week ago. I took a whole body MRI on Monday. She was very happy with it. The MRI showed no prostate cancer and no other types of cancer. She said that the radiologist found out that my bone spots that I had cancer in several places were healing. She could from one whole body MRI to the other. I've had 3 or 4 now. They could tell my bones were healing, which I'd never heard of before. So that was new to me. She then also gave me another Tempest test, which I had taken 4 months ago. She says, this new Tempest test is so much better than the old test that I'm going to use your November one as your baseline, and I'm going to order you Tempest tests every year from now on, but I need a second one to see if you're improving or not. or if anything is changing. So then she wrote to me after she got my blood tests, and she said, I want you back on orgovyx. I want you back on orgovyx. If you remember, she had taken both off-road drugs on the 28th of October, and about 20 days later, she put me back on darolutamide, and now she's put me back on orgovyx. She was, after she saw my EGFR score on my blood tests, which is 88, she says, I'll read to you what she said. Joel, the results confirm that your pituitary gland is trying to order testosterone production. We should restart the orgovyx, which I have. So that was another piece of news. So that's about it, unless there's any questions. Oh, yeah, no, there's one more thing. I knew there was one more thing. On my blood test, she ran something I never knew before, I never seen before. I know some of you guys, especially the doctors, know what this is. One's called a follicle stimulating hormone, and the other one is luteinizing hormone. And I'm way off the charts on those two. My score was 50.4, and the range is only 1.5 to 12.4. On the luteinizing hormone, my score was 26.7, and the range is only 1.7 to 8.6. First of all, does anybody know what these hormones are, and why am I so off the charts?
Yeah, I know what
What's
those
your
hormones are.
testosterone level?
24.
And that's why she told you your pituitary is attempting to really work hard to get your testosterone up and your estrogen up, and those hormones indicate, you know, what drives the pituitary, you know, and LH and FSH, follicle stimulating hormone, luteinizing hormone. Those are the ones that increase your testosterone, get your sperm and your estrogen and everything else.
Okay, so that has directly bearing to my production of testosterone.
Yeah.
Okay, so that's why it's off the chart. I thought it was
a
cancer.
Orgovyx.
Yeah. Yes, my testosterone now is probably closer to zero because of I'm back on Orgovyx for the last week. So that's my report. My question was those hormones, and thank you, Dr. Jack. Now I understand what they are.
It's important for us to be reminded that you can get housing when you go visit your doctors, and I thank you for reminding everybody of that, especially if it does turn out that Medicare stops paying for telehealth visits. And it's also good for us to all know about the genetic test, that there's a new genetic test, or at least an updated genetic test that we should be aware of. I also I have an article on follicle stimulating hormone, and I'd like to read. I haven't read it for a couple of years. I would like to read it and call you and tell you what I find out. Could you put in your phone number for me or your email?
Sure, no problem.
I'll get back to you after I've taken another look at that. I just dug it out. It'll do me good to review that also. Okay, David V. Gotta unmute, David.
I think it's Vern, David. I think
Vern.
it's Vern.
Oh, I'm sorry. I switched your first name and last name, and I remember when you first came that was going to be an issue, and I forgot. It's Vern.
It always is, but that's okay. Diagnosed in 2007, 4+3 Gleason score, had a prostatectomy. In 2015, and PSA rose, and I got radiation. 2018, it rose again, so I started on Lupron plus Zytiga. stopped in 2019. 2020 had a PSMA scan at UCLA and it showed lymph nodes involved. So I started on orgovyx and Vitiga and stopped it in 2023. And PSA started to come up again. So the oncologist said, just take orgovyx. Does that make any sense to just take orgovyx and not an additional drug like Zytiga or something else?
Well, we know now that it takes two drugs for advanced or higher risk cancers. So if you were a 3+3 or a 3+4, I might be inclined to say don't worry about taking just one. But if you are in a higher risk group, I don't think people taking just one do as well as people taking two. Can I get agreement on that from Len and Rick before we go any further?
I believe that's what the clinical trials show.
Yeah. So you have to tell us what your risk level is, either by telling us your biopsy results, your genetic tests, or your PSA level, or whether you're metastatic or not.
Yeah, I am metastatic, and the Gleason is 4+3. My doubling time was 3 months, and it is metastatic to the lymph nodes and a couple of bone areas. So I certainly am what I would consider high risk, and didn't get a good answer from him last time. I see him again tomorrow on why we're just doing one drug. And I've got several articles that show treatment intensification is better than treatment under treatment.
Right.
And to discuss them with him.
So I think it would be fair to ask him will I be safe from recurrence on only ADT without a second line drug?
Okay.
And I think it would have to be justified in some way. Was somebody else, Rick, was that you?
Yeah, I had a couple of questions. Is Dr. Singh still your quarterback?
I'm sorry, did you what?
Is Dr. Singh still your quarterback, doctor?
I quit going to Dr. Singh because he was not helpful. I guess I'll put it that way.
So who is guiding this treatment right now?
Dr. Riccio from the University of Arizona in Banner.
Right. Again, I'm going to say the same thing to you that I said to Carlos. You need a genitourinary medical oncologist. And I don't think I've not heard of Dr. Riccio. He may not be. If it was me, I would be switching my care to a GU medical oncologist. That's why you're having the issue that you're having. And I would suggest Dr. Bryce at City of Hope in Phoenix.
Okay.
And I would get to him as soon as you can and trust what he says. He's an excellent GU medical oncologist. He's accessible. Maybe you have to drive up to Phoenix the first time, Vern, but after that, you can probably see him. I don't know if you can see him telemed or not because of the change in the Medicare rules, but that's what I would do. This is the sort of thing we hear when you're seeing a general medical oncologist. When did you start taking the orgovyx yet or not?
Yes, I have. I've taken about 4 months.
So your PSA started getting high. How high was your PSA when he put you back on orgovyx?
A little over 1.
Okay, so That the best thing we can say, first of all, I agree with what Dr. John and Dr. Len said. You know, we seem to think that you need, as you found out, treatment intensification. That is the right thing to do. We've actually had a lot of discussion on that here at AnCan, and we even sent a letter and got published in the JAMA in JAMA in response to Dr. George's article. My feeling is that I would want my doctor in charge to be a well-known GU, genitourinary medical oncologist, and Dr. Bryce fits that bill.
Thank you. Thank you.
And I can put, if you know how to use the chat window, I can put the information for Dr. Bryce in the chat window for you.
Okay, I'll figure it out.
Now, ordinarily, I would open each of these questions up for more discussion, but because we've got to move quickly now, I'm going to go right on. So, David.
Hello, Dr. John. First of all,
Hello, David.
Hi, John. Good to see you. I'd like to thank, I've never had the opportunity to thank all the VAs, all the veterans for their service to our country. So from me to you, thank you. Just wanted to give everybody an update. So I went to see Schmulowitz, and I did another, I'm on the other, every 3-month program with Schmulowitz. I've been on a drug holiday since September of 23, and I got another 3-month pass a couple weeks ago. My PSA is hovering around 0.7, and my scans are clean, and I'm just enjoying another 3 months. I just wanted to give everyone an update. I'm so happy.
Huh.
That's my check-in.
Ooh, that was a...
Following Lens's trail here.
Oh, yeah. I mean, we like that, Mr. M, at 0.7, and we also like the fact that Dr. Schmulowitz is happy with you being, watching it at 0.7. So, and that you're doing well.
Yep.
Has he suggested a PSMA scan or not?
Oh, I did a scan. I do a scan. I do blood work, and I do a scan every 3 months.
Oh, okay. And what did the scan say this time? Any change?
Nope. Everything's negative.
Fantastic.
So I'm just rolling.
David, what type of scan are you doing every 3 months?
A PSMA.
Oh.
No problems with insurance?
Nope. They've been paying for it.
Terrific.
So I'm still rolling, all good. And I really stopped. I've been on a drug holiday since September of 23, which is when I stopped darolutamide. I was on monodarolutamide for 2 years.
That's great.
Yep.
Sounds great.
Don't go away, because Gary V wants to talk about monodarolutamide. So hang in, and we'll be back to you.
I'm back from the Bahamas, and I'm back in. I feel better. I haven't been here for a while.
That's okay. We still love you. And Vern, I'll put it in. I'm trying to do about 3 things at once. Keep notes, send this, but don't worry, I'll get it in there for you.
Thank you.
Seaman Schwartz, I see your camera is on, but I don't see you. Are you in hearing range? Bob?
Yes, I am.
Hi there.
We're hiding.
You wanted to mention something about your chemo.
I got volunteered by Rick.
Oh,
Rick.
Okay.
Yeah, we just want to make sure you're doing okay, because every time you come in and you say everything's fine, and we just want to make sure. How far into that chemo are you? How many sessions have you had? How many to go? And how are you feeling?
Well, first of all, let me say it's been helpful to see some of the past videos on AnCan, because I've seen some people that are even here tonight that can test what it's like to go through chemo, and it's much tougher than I even thought it was. But it's worth it. It's difficult, and there's like days, like for like 10 to 11 or 12 days, where you don't feel like eating. Food tastes horrible, and you got to force yourself, but you do it. But right now, the things are looking good. My readings went down from when I first started this at 325.74 to my last reading over 2 weeks ago, 0.82.
Wow.
0.8.
What are these PSAs?
Yes, PSAs. I'm sorry. And
Excellent.
what I'm on is Eligard injection 1 every 3 months, Nubeca, the 300 milligram tablets twice a day, and the chemos, the docetaxel, and I get the other shot for the white blood cells, the pegliflozin. I know I pronunciated it wrong. And my testosterone is now less than 10.
Okay.
But I will tell you, I have much more compassion and empathy for anybody who talks about going through chemo, because things happen to you you don't know, like your tear ducts just flow normally without even trying. It's like anything going on. You go to walk, the wind hits your eyes and the tears come out. You know, your nose, there's no nose hair, it's coming out your nose too. Like things you got to deal with.
How many more chemos do you have to do, Bob?
Two.
Two more.
Two more, hopefully, yeah.
Okay. Well, good job, and you're standing up after 4. So God bless you. You've done 4 then so far, right?
Yeah, I got the 5th one scheduled next week.
Okay, and are you? Do you have that sort of pattern where you have a low about 10 days after, and then you feel much better, and then you get another chemo?
Yeah, it's like you go from just feeling where you're going to be okay to feeling like hell again.
Oh, jeez. Have you lost much weight?
Yeah, during those 10 days, you go down about 10 pounds, and then you gain it back. So I'm fluctuating on weight. But one thing I am doing, I've isolated myself because I know my resistance is down, because I caught a cold on this already. It was really, really bad. And with everything else, I try and stay away from people. I wear a mask when I go out. I'm doing all the things that I feel keep me as safe as possible.
And your white blood cell count right now?
It's low, but with the shot that they give me, everything's hanging in there.
Okay. Stay away from that Lenciera. That's all I can say. But when you're better, make sure you reach out to him.
I'm looking forward to it. I am. I really am. I just, got to get through this thing first. But thank you.
Yeah.
I look forward to it also, Bob. You missed our reunion with a couple of other AnCaners, but I understand you got to protect yourself.
And not only that, I don't want to scare anybody with the way I look right now.
Hey, maybe Len can give you some of his Italian cooking. It's very good.
Yeah.
I love Italian cooking. Thank you.
Kurt, I got you next.
Super quick. Blood draw Monday, and my PSA is undetectable still. It's too new to get the testosterone let, but hopefully it'll be above 250. So.
Okay.
So
that's what we want to see, is testosterone testosterone coming back with PSA staying low, right?
Yeah, exactly.
Name of the game.
So
Rick?
are you off all treatment right now, Kurt?
Yep, just coasting.
Okay.
My let's see, the last injection I had was January ADT January 23, and that was a 6-month. So theoretically, I'm a year and a half about out of ADT. So
okay.
Feel good?
Yeah. Try, personal trainer and Pilates and and I've been doing pelvic floor PT, and that's been helping with lingering incontinence. So it's all improving. And I'll probably not be back in this group for a couple of months because we're heading to France for 2 months, and it's too late to join this group.
Yes, it is.
It
Yes,
is
it
indeed.
is. Mind you, if you could put together a group for France, we'd give them a group. We give them a group. So if you meet any peers there, let us know, and we'll start thinking about a European group.
Okay, will do.
Wear your blue ribbon, and people will notice you
Okay.
and say, "Oh, me too." Jimmy, do you want to catch us up? Jimmy must have stepped away. You there, Jimmy? Let's go to Gary then, and we'll get back to Jimmy. Gary V.
Talking to me? Oh, okay.
Yes, sir.
Just a quick question about monotherapy with darolutamide. My particular situation is I just went back on ADT. I had a little over 2-year holiday. And so I just started orgovyx on the 28th of February, started with Pluvicto on the 13th of March. And Rick said, throw the question out to the group about monotherapy because I've been looking at the studies with darolutamide, and they look very, very strong in terms of keeping your PSA low and allowing your testosterone to recover somewhat.
So you're wondering if you could drop the orgovyx and keep the darolutamide.
Exactly.
Go ahead, Lynn. I saw
Waiting
your
for
mic.
David, but okay, I'll go
Oh,
first.
okay.
All right, so Gary, I started taking darolutamide in September of 2019, along with Lupron, and by August of 2020, I stopped taking Lupron. So I haven't taken any ADT drugs in the past almost 5 years. So I've been on and off with darolutamide, and that's been managing my illness. I've had a couple. I haven't had quite as long a holiday as David has, but I had. What are you, David? Now, like a year and a half or more, I think, right?
Yeah, September of 23. I stopped
3.
there.
Yeah. Okay. So yeah, not only are we both doing monotherapy, but we're taking holidays in between.
So how do you work it? You go on the darolutamide, your testosterone stays strong. 6 months later, a year later, whatever, your PSA comes up a little bit, or a scan picks up something, and then you go back on Daro mono for a while. Is that how you're doing
That's
it?
exactly what happened with me, John. My PSA was creeping up. It was at 0.17 after about a little over a year of holiday, and so we did a PSMA PET scan, and a couple more Mets showed up, lymph node bone. So I went back on Daro monotherapy, and quickly brought it back down to undetectable. And then I switched to a half dose of the Daro.
Jeez.
And yeah, now that's with the knowledge of my oncologist. I would say do what I do. It's certainly not standard of care, but it works for me. So I'll let David pick it up from there.
Go ahead, David.
Okay, so what I've been doing since I stopped there in September of 23 is I've been every 3 months I do a PSMA scan, and I do a blood work, and the scans have been clean, And since May of 24, that was the first increase that I had from non-detectable. It went to 0.21, and then September of 24, it was at 0.73, and it's been hovering around there. It drops a little bit, it raises, but it's been hovering around there ever since. And my scans are clean. So with Schmulowitz's input, he says just play it out. Let's not do anything until something changes. If your PSA just hangs there and there's no Mets, live with it and it's all good.
But I'm going to get to the questions in a minute. But But Gary, these people have gone off their ADT and then even their Daro at times when their PSA was very low and they were basically in remission. But the last PSA I have in my notes on you was 2.9. Is that correct?
Yeah, that was my last PSA was actually on March 3rd, and that was 8.91. And my doubling, I was doubling pretty rapidly, to say the least. My PSA in September was 2.9, and it jumped to 8.91, but I was not on any ADT. I've been on that holiday for about 28 months. And my question is, those of you that are using darolutamide as monotherapy, my Gleason score was 4+4 or 4+5, depending on whether or not you believe UCSF or Johns Hopkins. So my initial diagnosis was I had pretty hot disease, but and I did not have a prostatectomy. I had radiation. So I'm maybe looking at this from a different perspective than the rest of you, and I would throw that out there as well. I don't know if that has anything to do with your success on darolutamide alone as monotherapy.
Well, Gary, I can tell you, I was also 4+5. I also had radiation therapy. I did not have prostatectomy. So my case is similar to yours. However, if I understood what you said earlier, your PSA is rising even while you're on hormonal therapy. Is that right?
No.
No.
What did you say?
No, my PSA was taken after I'd been on holiday. Was taken 3 days after I started orgovyx. So my PSA is more or less a reflection of being off of ADT. And I would say more of being off of ADT. And then
so
I
you're
have
still hormone sensitive.
Yeah, and as far as I know, I have lymph node involvement in my chest and ribs right now, and that's more than likely what is causing the rise in the PSA.
So you're wondering whether you have to go back on some type of hormone therapy because you're presumably still hormone sensitive, and you're wondering if you can go back only on darolutamide right now instead of orgovyx plus darolutamide.
Yes.
I don't know. I think I'd go back on both and then drop the ADT when I was stable. You guys?
That's probably good advice. Wait till you get down to undetectable, then maybe you can drop the ADT, continue with just the Daro monotherapy and see what happens.
Okay. And why not hot radiation to the 2 sites?
I had radiation to the 2 sites in September, but now I've got multiple sites. And Dr. Roach is my radiation oncologist. He's now looking at the possibility of maybe irradiating all of the sites that I've got right now, but he's not sure that he can do that, even him.
Well, then I think you definitely need a doublet. I mean, nothing to do it all after.
Yeah, if it was me, I'd hit it with everything and then back off. Jeff Markey, you have your hand up.
I was just going to say, I've been going through, after being on Daro for 6 months, Daro alone, my PSA is more than doubled every month. not my PSA, my testosterone has more than doubled every month. So I've been concerned about what Daro can do. And my oncologist told me specifically that Daro can eliminate about 250 of testosterone. Once it gets above that, then it's not able to fight it. And so that's why I have to be concerned about when to go back on. But it's after 16 months on it, I've been undetectable for 18 months on it, undetectable for 16 months, and 6 months for 6 months with just that alone. It works well. But like they say, I'd probably go on both again and then drop orgovyx.
How about you, Thomas? You have a comment.
I've got a question that relates to this discussion about drug holidays and monotherapy. And many times we're always pointed toward the guidelines or standards or whatever term you want to use. And I don't see anything about those types of treatments in the guidelines. I mean, that's neither here nor there, but I'm just wondering, is this a common thing amongst cancer treatment patients, advanced cancer treatment patients? Are they going to change the guidelines? Because so many men here on tonight's meeting are doing the monotherapy. And I mentioned that to my GU oncologist, and it's Dr. Sokolova. And she in my case, I'm pretty stable. But the answer to that question was no. It's nothing that's that's in the guidelines. She seems to want to stick to the guidelines.
Thomas, let me respond to that.
Okay.
So, Dr. Sokolova is young. She's probably been practicing as a GU med on 2 or 3 years. I remember when she first came on the scene. And it's easy for these younger docs to rely on, well, it's the guidelines, because they don't have the confidence or the experience to go outside the guidelines, and they don't want to take the chances. Now, a Dr. Schmulowitz or a Dr. O or a Dr. Rettig, all these guys who are willing to put men on monotherapy have a lot more confidence in their own ability. Now, I'm not saying Dr. Sokolova is a bad doc. I am saying she would not be a doctor. We wouldn't choose her, but we have no options right now at OHSU.
Right.
This is the problem at OHSU. The senior people, and I actually know for a fact the senior people think she's a good doc, but she's not seasoned. So, if we sent you to one of these doctors who's prescribing monotherapy, they probably would say, yeah, you're a good candidate. So you have to be careful. You have to be careful in terms of how we talk about the guidelines. We've been pushing Bayer to do a monotherapy darolutamide test for 4 years. Len, how long were we pushing Pooja? Forever to do a monotherapy Daro, and apparently that it's in the works. Although when I spoke to Zara, Dr. Zara last week, and I tried to get information, she wouldn't say anything about the monotherapy Daro. But go ahead, Len.
Yeah, Pooja said it was in the works, but I've never seen any evidence that it is. Oh, wait a minute now. I'm sorry. There was a trial, I think they called it Aranote, where they compared testosterone levels on monotherapy with darolutamide and monotherapy with enzalutamide. And the T levels rose significantly less when you're on monotherapy with darolutamide darolutamide than with enzalutamide. And they suspect that that is a good thing because you have less, the way they phrase it, with less feminizing effects, because you don't get the testosterone conversion to estrogen as much as you would, let's say, with enzalutamide. So,
Well,
yeah, go ahead.
I mean, Pooja told me, I don't think it's Aaron Oates she was referring to, because Pooja told me right before she moved on that they were finally trying to put in place a monotherapy darolutamide versus a doublet with ADT. But at the same time, I think it, and this is what we're hearing around with Gary right now, is I think it all depends when you go on to mono. You know, if you go on to monotherapy, if you try monotherapy when your testosterone is highly elevated, when your PSA is highly elevated, you might get a very different result moving to monotherapy darolutamide when you've already reduced that PSA. I don't know how they're structuring the trial. Maybe that's how they're structuring the trial. You know, bring it down and then flip over. We just don't know. But the point is, Thomas, that the more experienced the doctor, the more likely you are going to get treatments that are less conventional. And we shouldn't necessarily be relying on the guidelines. We hope the doctor prescribes to minimum guidelines. And minimum guidelines, as Vern pointed out earlier, is he should be on a second-line anti-androgen right now. But beyond that, we don't know.
Okay.
Yeah.
I'm gonna move things along. Jack has a comment, and then Carlos.
Oh, I don't have the comment any longer.
Okay,
Jack.
We'll remove you, Jack. Carlos.
Thanks for the opportunity.
Carlos.
Talking about monotherapy, that's something I would have loved to have started or tried in the past, but my numbers were just slowly creeping for several years until this Pluvicto. Now here we are, 35 weeks out, and since January, I'm now sub 0.1. I would love to get off of the Eligard. It's been 55 weeks or 55 months since I was put back on it. Thoughts?
I mean, I would say this isn't medical advice, but if it were me, I'd consider myself to be a great candidate to go on a monotherapy ARSI. And, you know, amongst them, we see darolutamide as being the best from looking at Len, looking at what's his name? My guy in Ventura, California, who Rettig put on. I can see his face, but with an H, I forget his name. But yeah, I mean, but you got no chance if you go to Goldberg or whatever his name is, because that's exactly what I'm saying. You know, well, it's not in the guidelines. He'll say to you, it's not in the guidelines.
You're exactly right. So, and I have been on Eligard and darolutamide combined for that full length of time, and it's like, okay, if it's under control, at what point can we say?
Well, but then you see
5 months out, 6 months out.
But you see, then you get it like the guy we sent to Reddit, and he went there on both drugs, and Reddick said to him, you know what, I'm going to take you off of the orgovyx. I just want to put you on darolutamide. That's what you get when you go to a doctor like that. It's not for you to ask. They're seeing it, and they want to give you the best quality of life. So they will respond. A Dr. Reddick will respond, whereas your local guy or a Singh or somebody like that or Sokolova, they don't do it.
Right. Okay. Thank you.
And I see that I see Cliff is back, Dr. John.
Cliff, we're over time, but if it's something that you want to bring up now, we can stay a little bit.
John,
This will be very quick.
hold
yeah.
on 1 second, Cliff. John, okay. I can stay. If you need to go, it's fine. It's perfectly fine.
Okay,
I'm happy.
thank you.
Okay, because I understand. You go, take care of Ray, and I'll finish it off and let you know if there's anything. So let me first go to Thomas for his comment, and then we'll go to Cliff and anybody else who still needs time. Oh, who still needs time?
That actually finished my list of people that were here on time. I didn't check with the people that came in after 10 after. I didn't check with.
I will check with them, and we thank you, much gratitude, and you are gracefully excused. Thomas, what did you want to say?
Yeah, I'll ask my question, but you can put me off till next week if you want to. I was just thinking, so how would somebody in my position talk to my doctor about this? Okay, she's young, experienced, not wanting to go out of the guidelines. Should I keep bringing it up? Should I be my own best advocate? And say,
yes.
Well, hey, Dr. Sokolova, now come on, how are you going to get any experience here? Come on, I'll be your guinea pig. Let's try it.
Well, I think, I'm not sure I would go it that way, but I would say, but no, and it's not a bad thing, but say, look, Dr. Sokolova, I'm really interested in doing monotherapy. And let me just tell you some of the doctors who are prescribing it for their patients right now. We know Dr. O's doing it. We know Dr. Schmulowitz is doing it. We know Dr. Reddig is doing it. We know that this isn't guidelines, but if you have relationships with any of those doctors, we know Dr. E is doing, say Dr. Efstathiou is doing it, because these are people that she knows, and she can call them up and she say, I've got a patient who wants to consider monotherapy. What can you advise me about that? And send her to patients that we know she knows, or that she can talk to, or she will respect.
Okay, very good, Rick. Thank you very much.
So I mean, try with Dr. E. That might be. I suspect she knows her. I think she knows her. Try with Dr. E, and she needs a mentor. She doesn't see. This is the problem. There's nobody even since Thomas Baer has gone. There's nobody even to mentor these younger doctors at OHSU. I see Gary V smiling, and it's true. It's true. So what are we doing as advocates? We're kind of creating this mentor system, and we can help behind the back. I mean, if she says, "Oh, I'll call Dr. Schmulowitz," I would call David and say, "David, give Schmulowitz a heads up that Sokolova is going to call about monotherapy." And so we can sort of work behind the scenes a little bit to try and create that. But if you know who she's going to call, let us know, and we can send a note to these doctors. We know them well enough. We know Schmulowitz and Efstathiou and Len could call Dr. O and say, look, this young doctor wants to talk about monotherapy. We're happy to do that. And the reason we're happy to do it is because if it works, and it's worked for a bunch of our guys, we know it's going to be so much easier for you men on this monotherapy because those are the results we've seen. Get it?
I would just put in a little bit of a plug for Sokolova. Yes, she is young, but she has already made a name for herself, and she is kind of pulling ahead of her peers. So I expect her to be able to be flexible and reasonable. Cliff, go ahead.
Yes, I recently experienced some blood clots and a little bleeding in my urine. It happened 2 days. What wasn't back-to-back days. I told my doctor, and they did blood tests, and they scheduled me for a CAT scan. Everything came back clean. I'm still on drug holiday, and my PSA is none undetectable. Has anybody experienced this before?
Yes, Cliff. Have you had radiation therapy?
Yes.
I suspect that you are developing radiation cystitis. This is a condition where even years after radiation therapy, an inflammatory condition occurs in the on the walls of the bladder, and bleeding occurs. It's generally speaking, it can be self-limited. You can have a few bloody episodes. My first pee in the toilet today was bright red blood with a few clots. It can come and go, wax and wane. It's generally considered a fairly benign situation. Although, in order to make sure that that's what you have, rather than something coming down, let's say disease in the kidneys, you probably might have to have a cystoscopy just to confirm the diagnosis. Go back and see a urologist and see if that's the situation that you have.
Okay, thank you very much, because you described it to a T. It just kind of came and went, and yeah.
So it scares me, even though I know about it. But unless over a period of time you become more and more anemic, it probably can be considered benign. And when it gets really nasty, there's even a treatment for that. But you might not. You're not there yet.
Okay.
Yeah, and I'll follow up on that. I had it too, and you're just at the right spot, about 18 months to 2 years out. We do see it more often, 18 months to 2 years out.
Yeah.
I made a deal with my urologist, and finally he said, if it comes back again, we're going to have to do a cystoscopy, which turned out to be a nothing. But they could see a little bit of the radiation cystitis, and I will tell you, it probably continued for maybe as long as 10 years after my treatment. I haven't seen it in a while. But the fact is, when it's bright red like that, I'm not that worried. It's when it's the darker red that sort of is a problem, and especially I have a more serious issue with the radiation damage, rectal radiation damage. But yes, so be assured you're not alone.
Okay. All right. Thanks. I appreciate the response.
And I think some who wanted to come. Oh, Steve, you wanted to say something on that too.
Yes, I don't know if you've had any stone issues before, but just last week I had noticed some blood and it turned out I had a camera sent up to look around, and there was a large stone blocking the coming through the prostate, and it was removed, and so for me it was dealt with quite easily with a looking at it a few times, and then just with a basket pulling it out of the as it was attached to the end of the prostate, apex of the prostate.
Okay. All right. Thank you, gentlemen.
Come back and talk to us if it continues, because we don't want it to continue. What we don't want it to do is to be a stone that gives you a lot of pain.
Yeah,
So,
I've never had kidney stones or anything like that. So
you don't want them. Let me just say, you never had them and you don't want them. I'm very interested. I see Frank C. nodding his head there. I'm more interested to know what Frank's been playing this whole time. He's been having a great time there. I've been watching him. He's plunking away on his guitar. That's I guess Jimmy's not. We lost Jimmy. Otherwise,
we lost Jimmy. He wasn't here when I called for
Jimmy
him.
would have been accompanying you, Frank. I guess we had a couple, Dr. John. That takes care of everybody. My only news, I'll give it you. was that after 17 years and 5 years of the promise test or whatever it is, 4 years, and then getting ready for closure, I thought, oh, I better sneak in under the wire and get my promise test. And I did do the promise test and it came back all negative. So that's great. All right, here we go. Go ahead, Frank. Go ahead. What you going to play for us?
I'm not playing anything. I'm just practicing. I mean, for me, I hate to have idle time, so I'm listening and I can have my guitar and just strengthen my playing. That's about it. But it was a good night. I appreciate everything. I had the blood issue too, but it went away. Thank you.
Thank you, Frank. We love having you in the group.
Thank you. I love being here.
Well, good night, everybody, and we'll see you all again next week.
Play us
Thank
out.
you, John. Thank you.
You're welcome.
Thanks a lot.
Thank you, John.
You're welcome. Bye now.
Bye. Phil, if you're still there, I saw you came in late. I hope everything's okay. I guess you stepped away. All right, we will cut the group.